Hello, everyone, and welcome to our IVF webinar. It's great to be back again with Dr. Carmen Morales. Hi, Dr. Carmen. How are you feeling tonight? It's great to have you back.
Hi, how are you? Fine, fine. Always happy to be here.
Thank you so much for joining us once again. And as I've mentioned, Dr. Carmen has been here already. Last week, we were talking about PGT-M. And tonight, as you can see, we will talk about PGT-A. And Carmen has prepared another presentation. And of course, she will explain step by step how it works. She will explain when it's recommended. And of course, afterwards, it will be time for your questions. So don't hesitate, type those questions in the chat section, and I'm sure Dr. Morales will be happy to answer them for you. And just so you know, Carmen, she is the genetic counselor, but also genetic department manager at Reproclinic, which is located in beautiful Barcelona. So thank you so much for, again, being our presenter. And of course, as you know, there are over 300 IVF webinars on My IVF Answers. And if you don't yet know, My IVF Answers is the part of European Fertility Society. And this society has been created simply because we want to help you out, educate. We want to give you the opportunity to meet top fertility experts as Carmen. And well, we just want to support the patients. We know that the IVF journey can be quite difficult, so that's why we thought about this, and we think that it's very, very helpful to you. So thank you, everyone, for joining us over and over again as well, because I know some of you come here every single day, so I do believe it's been very helpful to you, and we will continue to support you. So this is just, I wanted to mention this because definitely it's important for us. And now I think we can start with the presentation, right, Dr. Carmen?
Perfect. Yes.
Thank you so much. And of course, remember, the question Q&A session will start right after the presentation. You can type the questions during the presentation or afterwards, of course, as well. So thank you so much, and let's go ahead with our topic tonight.
Hello, everyone. Today I want to talk about preimplantation genetic testing for aneuploidies. So, first of all, I want to explain what is PGT. PGT is a genetic test that is performed on embryos that are created on an IVF cycle in order to detect genetic abnormalities. Based on that, we can do a selective transfer only of the unaffected embryos. This procedure requires to do a biopsy of the embryos in order to obtain sample for the analysis. So there are basically three different types of PGT. We have PGTA for monogenic disorders. That is the one I was talking last week in the webinar. And this is specific for couples with a known genetic disorder in the family. Also, we have PGT for structural rearrangements that are couples that one of the members is carrier of one structural rearrangement, that it's when you have the normal amount of DNA, but you have some chromosomes that has interchange, for example, DNA. For example, in the case of reciprocal translocation, you have two chromosomes that they just interchange some genetic material. These patients are healthy, they are completely normal, but they are at risk of producing what we call unbalanced embryos. These embryos are having an abnormal quantity of DNA and usually are ending or in a miscarriage or in a baby with severe abnormalities. Also, we have PGTA, that is a PGT, preimplantational genetic testing for aneuploidy, that before was called PGS. And it's the test that I'm going to explain in detail tonight. For all kinds of PGT, they are performed more or less the same steps. We need to do an IVF cycle, okay, in order to produce embryo. We need to biopsy these embryos, that the biopsy can be done in day 3 of embryo development or day 5. With the biopsy, we are going to obtain some samples from the embryo that are going to be sent to the genetic lab for the genetic diagnosis. The embryos are going to be kept always in the IVF clinic. Since the genetic diagnosis usually takes some time to get the result, and we cannot keep in culture for so long the embryos, these embryos usually are frozen, and when the genetic report is ready, they can be thawed and transferred only the normal ones, the unaffected ones. Regarding the embryo biopsy, as I told you, it can be done in day 3, that is the first image here, that it's done in cleavage stage. The embryo is still, we can distinguish the different cells. Usually it's having between 8 to 10 cells. We are making a hole in the zona pellucida of the embryo, and we are removing one cell. This cell we are going to put in a small tube, and we are going to send it to the genetic laboratory. Also, the biopsy can be done on day 5 of embryo development. We are going to do the same hole in the zona with a laser. Usually it's with a laser. We are going to remove from this external layer of the embryo, that it's called trophectoderm, a small piece. Usually it would contain 5 to 10 cells, and this small piece of sample it's going to be sent to the lab for genetic analysis. The main difference is here we are getting only one cell, and here we are getting several cells that we are going to analyze all together. We cannot analyze the sample cell by cell. So before starting with the PGT itself, I want to introduce some concepts of genetics in order to understand better why we are using PGTA. So first of all, what is a karyotype? A karyotype is the picture of a person's chromosomes and allow us to determine the chromosome complement of a person, including the number of chromosomes and the structure. A normal karyotype is having 46 chromosomes organized in 23 pairs. Meaning from each pair, we inherit one chromosome from our mother and one chromosome from our father. So the difference between the male and female karyotype is that female will have 2 chromosome X, and male they have 1 chromosome X and 1 chromosome Y. We have that karyotype can be normal. We have a normal complement, 46 chromosomes. We can have abnormalities in the structure of the chromosomes, as I told you. For example, reciprocal translocation, 2 different chromosomes interchange a fragment. Okay, the total amount of the DNA is balanced. Okay, in these patients they don't have extra or missing DNA. And we can have also abnormalities in the number of chromosomes. That is what we call aneuploidy. If we have missing chromosome, this is called monosomy, and if we have extra chromosomes, this is called trisomy. Most of the aneuploidies are not compatible with life. Very few of them are viable. For example, we have trisomy of chromosome 21 and all the aneuploidies that are related with sex chromosomes. So most of the embryos or fetus cannot survive with missing a monosomy or extra trisomy chromosomes. And this is related to implantation failure and spontaneous miscarriage. Some others can survive till birth, leading to a baby affected of a genetic syndrome. For example, here we have a karyotype of a trisomy 21 with a baby that is having 3 copies of chromosome 21 instead of 2. So it's well known that chromosomal aneuploidies, they have a great impact in human reproduction. From all the conception or natural conception, we are talking this about natural conception, most of them are lost in the early stages. Okay, we call them preclinical losses. And these preclinical losses cannot be tested directly, cannot be analyzed. However, a reflection of what is happening here can be what we detect in IVF embryos. Here we have the percentage of aneuploid embryos that we can detect per age. Okay, we see that the percentage of aneuploidies increase with maternal age, but for all group of patients, even the younger ones, we have an important percentage of them that are having aneuploidies. It's never less than 20% of the embryos. When we are analyzing clinical miscarriages in this segment here, we can find that about 50 to 70% of them, depending on the study we are comparing, they have chromosomal abnormalities. Okay, usually the most frequent one is autosomal trisomies. Okay, this is the most percent. So PGT for aneuploidies allow us to detect abnormalities in the number of chromosomes, aneuploidies, and select for transfer the embryos that are chromosomally normal, and that we call these embryos euploid. By doing that, we want to help the couple to increase the pregnancy rate, decrease miscarriage rate, reduce the risk of having a baby with a chromosomal syndrome, and also reduce time to pregnancy. PGTA has evolved in last decades regarding the technologies used, the chromosomes that they can analyze, and the type of biopsy performed. When PGTA started, we were only able to use a technique was called FISH, fluorescent in situ hybridization, and this technique allows us only to check for a specific number of chromosomes. Usually we are testing 5 to 9 chromosomes, and the test was done in day 3 embryo biopsy. Nowadays, the most used technology is next generation sequencing, NGS, that allow us to test the whole chromosome complement. We are testing all the chromosomes, and the biopsy is mainly done on blastocyst stage in day 5 of embryo development. So most of the aneuploidies we are detecting in PGT-A are what we call from meiotic origin. I mean, if there is a mistake during the gamete formation, even if it's egg or sperm, that gives an egg or a sperm with an abnormal number of chromosomes. This gamete, it's fertilized and it's giving an abnormal embryo. In that case, we have a disomic, let's say, egg that after fertilization with normal sperm is giving us a trisomic embryo. It can happen the same if in the gamete it's missing one chromosome, for example, chromosome 21. Like here, we are going to have an embryo with monosomy 21. I put here some examples of the profiles we are obtaining when we are analyzing these samples from the embryos using NGS platform. Okay, here is the profile we obtain for an euploid female. That this corresponds to this kind of karyotype 46XX. For a male embryo, euploid male embryo, we obtain this profile we have here. Okay, this is the chromosome. And for a Down syndrome, trisomy 21 embryo, we obtain this pattern here with find here, we have a trisomy of chromosome 21 that will correspond to this karyotype. So we know there are a subgroup of patients that they are at higher risk of producing gametes, eggs or sperm, with aneuploidies, with an abnormal number of chromosomes. These abnormal gametes, after fertilization, will give aneuploidy embryos. So this group of patients, they are at risk of having aneuploids, abnormal embryos. This group of patients are advanced maternal age patients, recurrent miscarriage patients, recurrent implantation failure patients, and male factor patients. Okay, so the patients that can mainly benefit from PGTA are patients included in these subgroups, patients that they have fertility issues, that they are going to do an IVF, and since we know that they are at higher risk of having abnormal embryos, we can recommend them to do a PGTA in order to select the normal, the euploid embryos. These euploid embryos, they will have the higher potential of implantation and achieving an ongoing pregnancy. The first group, patients with advanced maternal age, we include in this group patients older than 36, 37 years old. It's well known that with aging, the chromosomes in the egg are less likely to divide properly, leading to eggs having extra or missing chromosomes that after fertilization will give an abnormal embryo. I showed you this graphic before, but this is very clear. We can see as maternal age increase, the percentage of abnormal embryos also are increased. And for patients of 43, 44 years old, the percentage of abnormal embryos in an IVF cycle can be as high as 90%. Another group of patients that can benefit from PGTA are recurrent IVF failure patients and recurrent pregnancy loss or recurrent miscarriage patients. For this, obviously, there are different factors that can be the cause of the IVF failures or the miscarriages, like uterine abnormalities, autoimmune disorders, thrombophilias, etc. So the gynecologist, the physician, has to order the proper tests and examinations in order to rule out all these disorders. In some patients, it's not possible to find the clear cause of the IVF failure or the recurrent miscarriages. So in that patients, we cannot discard that this was related to aneuploidies in the embryos that are causing these failures of implantation or these miscarriages. So these patients can also benefit when they are doing an IVF cycle of PGTA testing. Also, we have patients with severe male factor. And these are couples with the male is having abnormal sperm parameters. And we know that this is abnormal sperm parameters correlates with a high rate of aneuploidy in this sperm that, as I told you, after fertilization will lead to aneuploid embryos. One of the abnormal parameters that correlate clearly with high aneuploidy rate is when patient is having oligozoospermia, low sperm count. Here I include this study where they are comparing a control group of patients plus the study group of patients that are patients with severe male factor. Here we have that these couples, they are having around 35% of the embryos are abnormal during the IVF cycle, while the patients with male factor, this is increased to 51%. And if we are distributing the patients as per the sperm count, oligospermic patients, they have a higher, even higher rate of abnormal embryos, up to 64%. So it's proved, it has been proved that this group of patients, they have high rate of abnormal embryos, and they can benefit from PGTA. I also want to introduce you or to explain you a little bit the concept of mosaicism in PGTA, because it's nowadays a very controversial issue. Okay, sometimes when we're analyzing the embryos in the profiles I showed you before, here is the profile of the software from the NGS analysis, we can find these intermediate profiles. Okay, this is not here. This is chromosome 7. Okay, here we have that there is something in chromosome 7. It's not normal for chromosome 7, but it's not a complete trisomy of chromosome 7. So this pattern can be compatible or can be consistent with a mix in the sample of cells with a normal karyotype, with a normal complement, and some cells with trisomy 7. And this is what a mosaicism is: the presence of two or more cell lines in the embryo that are genetically different. Okay, we know that mosaicism happens in natural pregnancies because in 2% of colonic villus samples and in around 0.5 amniotic fluid samples, we can detect mosaicism in natural pregnancies. However, the percentage of mosaicism that is detected in IVF embryos, it's much higher than that. It can be around 10 to 30% of mosaics. This percentage is very variable because it's related to the laboratory doing the analysis because of the platform they are using, the cutoff they are using, etc. So it's also related to the lab. But anyway, it's much higher than what we found in prenatal samples. I have to tell you also that these intermediate profiles are consistent with mosaicism, but can be caused by other things. We can have, for example, a contamination of the sample with external DNA. There can be a technical artifact if there is a bias in the DNA amplification. Also, it can be explained by biological factors depending on the phase of the cell cycle the cells of the sample are, etc., etc. So this profile can be explained by mosaicism, but there are other factors that can explain the mosaicism. So before I was telling you that the aneuploidies that we are getting with PGTA are originated or they have the origin in the gametes. Okay, there is a mistake, an error during the production of the gametes. But mosaicism is having what we call a mitotic origin. It means it's originated by a mistake in the embryo itself. We can have a completely normal embryo that during the cell division of one of the cells, or for example this one, the cells is making a mistake during the cell division, and it's giving you two daughter cells, one with trisomy, another with monosomy. So at the end, we have an embryo that it's a mosaic. It's having normal cells with 46 chromosomes, and some cells with 45, and others with 47. Okay, these trisomic cell lines, they are going to divide, and they are going to give a full cell line, all with trisomic cells, and the monosomic cell the same. So at the end, we will have an embryo that can be a mixture of cells, normal with trisomies, with monosomies. Okay, And these different cell lines can be distributed randomly in the embryo. Another factor that can influence the diagnosis of mosaicism is the biopsy technique itself. Because if the cell lines are distributed randomly, we are doing the biopsy also randomly. I mean with that we are choosing randomly this area here to make the hole and obtain the cells. But if we may be analyzing these cells, since the distribution of the abnormal cell line can be different in the different parts of the embryo, at the end, the result that we will have can be different. This can also, the place where we are taking the sample can influence and can change the diagnosis of the embryo. So, with the development of these very sensitive technologies and the application of the day 5 biopsy, that it's safer for the embryo compared with day 3, we are now able to detect these mosaicism. Okay, I have to say, if we are analyzing the embryos in day 3, we cannot detect mosaicism since we are only analyzing a single cell. So there is a single cell. Even if the embryo is mosaic, we are only going to have the result of this specific cell. In day 5, we have a mixture of different cells, so we can detect this intermediate pattern. So we have that now, apart from the euploid embryos that are the normal one, the aneuploid embryos that are the abnormal one, we have a third category of embryos that are the potential mosaic embryos. We are saying potential because we detect an intermediate pattern, and this can be compatible with a mosaic on the embryo. So what we can do with these embryos, because at the beginning the outcome of this embryo was not clear, and nobody was transferring these embryos. Okay, these embryos usually are discarded. But after a while, some studies were conducted, and some clinics they start to transfer these embryos in patients that they don't have normal embryos to transfer. Okay, so all these clinics, all these studies, they publish the results, the outcomes of these pregnancies, and we saw that these mosaic embryos were able to implant and to give an ongoing pregnancy and to give a healthy baby. Okay, if we are comparing the results after the transfer of potential mosaic embryos versus controls that are euploid embryos, we see that there is a reduced implantation rate and reduced ongoing pregnancy rate and increased miscarriage rate for these potential mosaic embryos compared with normal embryos. However, it's generally accepted, it's worldwide accepted, that these mosaic embryos can be considered for transfer in couples that they don't have normal euploid embryos for transfer. Okay, and this should be done after proper counseling of the couple, after explaining them all the risks they have. Also, different societies and groups have published in the recent years guidelines, position statements, etc., regarding how to prioritize the mosaic embryos for transferring, depending on the type of chromosome that is involved in the mosaic or the percentage of abnormal cells that this embryo can have. Since the very beginning, PGTA has been a very controversial test. We have a group of professionals that they are saying that this test is not beneficial for the patients. Some of them, they are saying even it's damaging, it's costly, and it's only having commercial interests behind. There is another group of professionals that I think it's the majority, that it's saying that yes, that this test can be beneficial for patients, especially for a specific group of patients. A subgroup of patients at higher risk of producing abnormal embryos. And if we have the technology available, maybe it's not ethical not to offer this technology to this patient that we already know they are at higher risk. Looking to the state or how PGT is in Europe now, we see that if we're comparing PGTA with PGTA and PGTM, it's allowed in almost all countries that are performing assisted reproduction techniques. Okay, there are differences in the policies applied for each country, the list of diseases that are allowed, how to if you need to apply case by case approval, etc. But generally, it's allowed in almost all countries. However, PGTA is more restricted, and there is still a good number of countries that are not allowing this technology. Here I include some data. This is the last data published from the PGT consortium, that is data collection from 2013 to 2015. Okay, with the cycles with indication of PGTA. So around 20,000 cycles were started with indication of PGTA, and around, in this 3-year period, around 80,000 embryos were analyzed and were genetically transferable, meaning genetically normal and able and can be transferred safely, around 28% of them. If we are analyzing by the indication for the PGTA, we see that almost all cases are indicated because of advanced maternal age. Also here I include a comparative between the successfully biopsied embryos by different type of indication, and the ones that are genetically normal and can be transferred. You see, it's, most of the embryos are abnormal, and a low percentage of them are normal and can be transferred. The main difference is here, because in others I include the patients with egg donation, cycles with egg donation. So egg donors are young and are a good prognosis patients. So we are not expecting on them a high proportion of abnormal embryos. So in summary, PGTA is for couples at risk of producing embryos with aneuploidies, and PGTA can improve the clinical outcomes, especially by reducing the pregnancy loss, the miscarriages, and the chromosomally abnormal pregnancies for a selected group of patients. The group of patients that has shown more benefit of this is patients with advanced maternal age. Despite all of this, the application of the use of PGTA is still controversial, and there is great variability among the different countries regarding the acceptance of the PGTA. And thank you very much for your attention, and I'm open to all the questions you may have. Thank you.
Thank you so much, Carmen. Thank you so much for being back with us. As I mentioned, you've been here before, of course, last week. And again, amazing presentation. You've explained everything very thoroughly, and it's definitely an interesting topic that brings lots and lots of questions. And as you can see, there are some questions ready. So let's get to them. Let's start with our questions from the patients. Let's have a look. The first one is ready here. So is there a known cause for meiotic issues in the embryo causing mosaicism? Can these be a problem with the culture in the lab?
Well, And if the conditions of the lab are not good, it's true that you can have a lot of abnormal embryos, not only for chromosomally abnormal embryos, also morphological abnormal embryos. Okay. Yes, the conditions in the lab, if they are not optimized, they can cause abnormalities in the embryos, and they can be a source of aneuploidy. Yes. So for this reason, the protocols and the conditions in an IVF lab, they should be checked, and they have to follow very strict protocols also, you know, if so. Yes, in fact, these iatrogenic conditions can influence in the quality of the embryos and in the component of the chromosomes of the embryos.
Perfect. Thank you so much, Babu, for your very first question and, of course, for your answer. And I will go straight to the next question. Actually, it is also from Babu, okay? So let's have a look. So if I'm correct, the graph you showed from Franchak shows that younger women have a higher aneuploidy rate than, example, 28-year-old women, which showed the lowest rate, in egg donation. Would 28-year-old be the best for an egg donor?
Well, it's true that very, very young woman, very young, I mean 16, 17 years old, can have a higher rate of aneuploid embryos, but it's also true for the risk of Down syndrome. You know, it's also known that when mothers are very, very young, they're having higher risk of having a Down syndrome baby. However, well, this is a result from this study showing, I don't exactly know how many patients of 28 years old have. I put this as an example. Most probably, if you are using the graphics from another publishing, maybe the percentage, maybe it's a little low in 27 years old patient. I cannot tell only with the results of one study that 28 years it would be the best of the ages, because there is not very big difference between 27 or 29. I think before 30 years old, I think they are the best results for egg donors. But I cannot tell you a specific one age based only on the graphic of one study. It's true that if patients, the donors or the woman is very, very young, there is a higher risk that it's on her 20s, that it will be the best age, the best for reproduction.
Perfect. Thank you so much, of course, for that follow-up, and Bubble, and of course for your answer to this question. Let's have a look, okay? Some more questions are coming up. Also, again, sorry, from Bubble, one more. Was it possible to detect mosaicism with the old technique using fish and day 3 biopsy?
The only way that mosaicism is when you have different cell lines. Okay, for example, you have one cell line that is completely normal, 46 chromosomes, and one cell line that is with trisomy 21. Okay, if you are only analyzing one cell, you cannot detect different cell lines. Meaning, if you are doing the biopsy on an embryo of day 3 that is a mosaic, and by chance, because it's randomly, you are taking the cell that it's normal, you are going to diagnose this embryo, even if you are using fish or you are using NGS or array CGH, doesn't matter, because you are only analyzing one cell. So if you are taking randomly the normal cell, then you are going to give a normal result for this embryo. Okay, if you by chance are taking the cell that is a trisomy 21, so the diagnosis of this embryo will be a trisomy 21. Since you are only analyzing one cell, that is recommended in day 3 only biopsy one cell, because more can damage the development of the embryo, you are not able to detect mosaic by fish or by any other technique you can apply, because you are only testing one cell, so not possible to detect mosaicism.
You again for clarification to this question as well. All right, next question is here. Your data shows Sant is the best at PGTA. What lab do you use in Spain?
Okay, my data shows Sant is best. Okay. We are collaborating with different labs, but I don't want to say here some labs, genetic labs are better than other. As I told you, for having very good results in genetics, you also need to have very good conditions in the IVF lab. Because the quality of the embryos is also important. I mean, if a laboratory is biopsying everything, even embryos of very poor quality, then most probably these embryos will be chromosomally abnormal, okay? And then you will have very bad results. And you can say, oh, this lab is giving me very bad results. No, you are giving them very bad samples. So it's a conjunction of both things. You need very good conditions in the IVF. You need to choose the embryos you are going to biopsy in order to can have good laboratory results, because you can see a lot of variability. Even a same genetic laboratory that is receiving samples from different IVF labs, it can be a great variability between the results. And the genetic lab, it's the same. It's just the IVF centers are different. They have different conditions. Also, they have different patients. Some centers are specialized in very difficult cases. Okay, so the probability of abnormality in the embryos it's higher than other that is doing IVF to everybody and accepting PGTA for egg donation patients, etc. That are very good prognosis patients. So it's not only the genetic laboratory. I think it's all together. Okay, that it's giving you good or bad results.
Well, thank you so much, of course, once more. And there's a thank you from Derek for you. I understand. Thank you. Okay, next question. At least for now, there are like 2 questions, I think, left. So if you have anything else you would like to ask, go ahead, type those in, okay? Let's have a look. Kate has added, what about egg donor recipients? Is there any benefit from PGTA to improve pregnancy outcomes?
Okay. There are 2 tendencies. There are some professionals that they say, since we can detect abnormal embryos in all in all ages, even in young patients, even the percentage is not very high, but it can be 20%. Let's do PGTA to all patients. Okay. On the other hand, we have the other group of professionals that they don't see an advantage of doing that, and they decide to offer only PGTA for a specific group of patients. Okay. What is true is that according to the published data, a PGTA is improving the outcomes mainly in patients over 35 years old. In young patients, including egg donors, if there is no other factor like a severe male factor or nothing else, the published data didn't show an improvement on the results. Okay, so in my opinion, but this is my opinion, and there are different policies, different tendencies, I will recommend only the PGTA to specific groups that we know that they are at higher risk in order to see a benefit of this test.
Kate, for that interesting question, for sure, and also for sharing your opinion. Yeah, because that's why we are here. There are different, as you said, two different options here as well, and to many opinions. That's for sure when it comes to that. But thank you, of course. And let's have a look. At least at this point, I don't see more questions, so we will be finishing. However, this is like the final call. If you have anything else you haven't asked yet, do it now. And if not, we will be finishing. But I do believe it has been very, very useful already. Lots and lots of details you have provided again. And this comment definitely is a great summary for this. Thanks, Carmen, for the presentation. I have learned so much tonight. I didn't think this was possible. Thanks for sharing your knowledge and answering my questions.
Okay, thank you very much. I do my best always to try, because I know some complicated concepts about genetics, but I'm trying to make it easy. I don't know if I do it or not, but I try. And if there are other questions, there is my email, and they can send me all the questions they might have.
Perfect. Thank you so much, Karen. Carmen, sorry. As you can see, many things are coming up your way. So that means it's been useful for sure. And it means that it's very clear for the patients. So thank you. Thank you so much, everyone, for joining us tonight, for your questions. As always, it's great to see that it's interesting. You find it interesting. And of course, Carmen, you did a great job. Thank you so much for joining us. And if, again, someone missed any part of this, remember it has been recorded. You will have a chance to watch this again on My IVF Answers, as you know. And also it will be available on our YouTube channel. So subscribe. That way you will be notified when the video is actually uploaded. And what else can I say? As you know, we will be back tomorrow at 8 p.m. UK time. We will discuss PGT-SR. Carmen has already mentioned some things about it, but of course tomorrow Dr. Luca Generali will be with us and he will discuss it more thoroughly. So I hope you can join us as well. I'm sure it's going to be interesting as well. And again, Carmen, it's been great to have you here. Thank you so much. And of course, I do hope that we will have more opportunities to cooperate, and I hope to see you and of course as our presenter very, very soon as well.
Thank you very much for giving me the opportunity to explain these topics here.
Thank you indeed, everyone. Have a lovely evening, and I hope to see you tomorrow. Thank you. Take care. Bye.